Mr. Pound, could you please turn to the bundle in front of you? You should have volume 5, and you should see in front of you your submission. It's the one I think that's open directly in front of you already. Can you please confirm, first of all, your full name and professional address?
Yes, my name is Stephen Pound, Member of Parliament for Ealing North.
I should say as well that, in fact, the button on that thing amplifies, and please do sit or stand as you feel more comfortable.
Thanks very much indeed. And my professional address is the House of Commons, Westminster, South-West 1A, OAA. And may I apologise for any inconvenience that I have wished upon the Commission by having to leave early. I do apologise. I'm not being precious. I just really do have an engagement that is absolutely, utterly unmissable.
Not at all. Can you please confirm that the submission there is true and accurate to the best of your knowledge and understanding, and that you wish it to stand as your evidence to the Commission?
I can confirm that this evidence is true to the best of my recollection. In fact, to my knowledge, it is correct, and I wish it to stand as evidence in my submission.
I'm being reminded, if you press the button on that, a red light should come on,
yeah,
which will amplify.
Is that better? Sorry, it's okay.
May I just check, from people in the gallery at the top here? Yep, good, thank you. I wanted to ask you first about the consultation phase, please. Yeah. How well do you consider that your constituents were informed about the proposed changes?
My constituents almost unanimously were utterly confused by the whole process. I can't think of an occasion when there's been less engagement and less sense of ownership in anything. In all honesty, we're actually more engaged with the Heathrow Airport consultancy than we were with this. This is much, much more important. The whole Shaping a Healthier Future exercise was glossily produced in wonderful documentary form, and there were a couple of meetings, but the degree of local engagement was profoundly negative, whereas the degree of local opposition was extremely positive, widespread, and attracted enormous numbers of people.
I wonder if I could ask you just to have a look at volume 1, which is in front of you as well, and just please turn to page 77. This is a submission which has been provided by the London Borough of Ealing, and I wonder if you can see paragraph 5. It's headed "The Changes Set Out."
I have it, yeah.
And what it says there is that public participation was confined to SAF engagement events, which were attended by in total approximately 360 members of the public. Can you help us with whether or not that accords with your own view of things? Is that accurate or not?
That is extremely accurate. In fact, in my submission, I specifically refer to the fact that I wish to associate myself with the submission made by the London Borough of Ealing and the leader, Julian Bell, who's going to give evidence later on today. More people attended the first public meeting in opposition, which was held in Hanwell Methodist Church 2 years before that, than did in the whole of the public consultation from the SAHF exercise.
And still on that consultation exercise, are you able to say if, as I think you are saying, that the information did not reach all your constituents, were there any particular groups who were least informed?
Very much so. I mean, one of the specific features of Ealing is the demography of Ealing. We have a great many people who do not speak English as a first language, who in part were excluded from the process. We also have a large number of elderly people and people who weren't accessible through the normal mechanisms, i.e. doctors' surgeries, because we have a great many single-handed practitioners and we have a significant number of elderly single-handed practitioners, particularly in the west of the borough. I was constantly being contacted by people who had heard apocalyptic stories about the closure of the whole process. But in some cases, their fears were genuine. In some cases, they weren't. But the one overriding constant feature was a lack of comprehension, a lack of engagement, and a lack of penetration into those communities.
And just to be clear, when you refer, and this is at paragraph 9 of your statement, to the uniformly negative response from constituents, is that something which over the time has got better or worse or remained a consistent feature?
Sadly, it's got worse for a couple of reasons. I did specifically make the point in my submission that there are cases when major reorganisations in the NHS have to happen, do happen, and in fact are successful. I'm thinking of the closure of the hospital I worked at for 10 years, the Middlesex Hospital, which was closed and is now a hole in the ground instead of a glorious mid-Victorian, wonderful building. But it was not controversial because it made sense to people. The consolidation of stroke services, initially controversial, when it was explained, when the public were engaged with, and when it was explained that the medical advances in TIAs and various other mechanisms could actually make the process better, people understood it. In this particular case, people didn't understand it, and it's a terrible coincidence that this actually coincided with what I would say is a fragmentation of NHS provision, where we have a sort of a notional health service in West London rather than a national health service, because it is utterly disaggregated at the present time. So those factors came together, and the one at the end of it, the absolute utter hammer blow, is this absurd letter that's been circulated this week to say that maternity services will be removed from Ealing Hospital because although they're fine at the moment, at some stage in the future they may not be, therefore let's close them down now.
Can I ask you to pause there? I was going to come to that, but we may as well deal with that issue now, as you've touched upon.
Sorry.
You were referring to a letter from Dr. Mahini Palmer, is that correct?
I'm referring to the email I received dated the 19th of March from Andrew Pike, sent on behalf of Dr. Mahini Palmer.
And the substance of that, very briefly, is what?
Is that Ealing Hospital Maternity Unit, and I quote, is currently a safe place for women to give birth. However, the standards for maternity units are changing, and we know that in future Ealing may struggle to meet these standards. End of quote. In other words, my house may be a perfectly adequate home for myself and my family at the present time, but at some time in the future the roof may leak, therefore let's knock it down now. An absurd, ridiculous, tendentious statement that is absolutely inexplicable in any other context other than a wish to centralise maternity services, to remove all maternity provision from the London Borough of Ealing, which is not only deleterious to my constituents, but a disaster.
Can we look at that a little bit more and break
Sorry,
that down? No.
I did say flipping.
If that service is closed, what specifically will be the impact on the service users?
For a start, there will be of immense significance the fact that there will be no maternity service within the London Borough of Ealing. They will then have to go to other maternity centres. Now, like virtually everybody I know, I was born in Queen Charlotte's Hospital. Queen Charlotte's Hospital was the maternity hospital. Many people went there. It's no longer at Queen Charlotte's Hospital. You know, it isn't there. It's now consolidated within Hammersmith. So people would then have to move to West Middlesex, which appears to be the preferred option. If you don't know the Borough of Ealing, you might think that West Middlesex Hospital is a stroll down the road, so some gentle sylvan glade like Windmill Lane. You can sort of wander through the hayfields. In reality, you've got to cross the M4 to get there. And there isn't a direct bus route from the vast majority of my constituency. There's no tube station anywhere near it. So the idea that you can up and stroll down to West Middlesex is ludicrous. It may make sense looking at a flat map, but anyone who's spent 3 minutes in West London will tell you it simply isn't on.
Now, in terms of the consequences for particular groups, you've mentioned a large non-English speaking constituent. Does the potential closure have any particular consequences for that population?
Yes, it does. The maternity services at Ealing Hospital opened in 1988. Up until then, we had had 3 maternity hospitals in the borough, the most famous one obviously being Perivale. Between 1988 and the present day, Ealing Hospital's maternity services have actually won for themselves a reputation of being a first-class service, which is not just excellent in terms of maternity services, antenatal and prenatal ones, but also in terms of the accessibility to the local community, in terms of nurses, staff, doctors who can actually speak community languages, and also the provision and the structure within the system. Cultural sensitivities are incredibly important at this particular time. I'm sure I don't need to make that point. Ealing Hospital is a very, very culturally sensitive hospital, and the maternity services are a safe, reassuring and comforting place for women to give birth in. And it took a long time. It took a long time for them to reach that. And at the present time, with some of the best maternity nurses I've ever known in my life, and some of the best midwives, leaving because of demoralisation, because of what they could see coming over the hill was the closure of the service, that is disappearing. And I'm already getting the complaints from people are coming in. And there are, I don't wish to go into specific areas, but there are certain aspects of maternity which really do need to be handled extremely carefully. And also, if you look at the FGM issues nowadays which need to be identified at that stage, that is something which is incredibly sensitive. Ealing is good at that, and we are throwing all that expertise, all that institutional memory, all that sensitivity, all of that is going to get thrown. I'm not saying West Middlesex can't do it. I'm saying it'll take a long time for them to get to do it, and people will suffer in the interim.
Now, thinking about the decision-making process which is taking place, do you have any view about the impact of the delay and then further delay upon staff and users?
Well, absolutely right. I mean, I referred to in my submission to the statement made by the Royal College of Nursing, and they make the very, very powerful point that this is absolutely demoralising to staff. I quote in my submission the statement made by the Member of Parliament for Ealing Central Acton, which he said on the floor of the House, and I quote, "This is all about money." I think that Angie Bay was absolutely correct on that, and certainly a large number of staff say, look, we are dedicated and devoted to the National Health Service. It is important to us. These decisions appear to be taken, and our own MP has told us this, on fiscal grounds alone. This is not actually about any sort of therapeutic imperative. This is actually about money. How demoralising is that? And you can see with your own eyes the staff moving away from there. Why have we got a crisis in employment with midwives in Ealing at the moment? I would say to a very large extent because who on earth would take a job at the present time knowing that your job will be disappearing soon?
And just finally thinking on this point about the maternity hospitals, in the documentation provided on behalf of Dr. Palmer, and there's reference to it in earlier documents, I won't take you to them unless you wish me to, the thrust seems to be that other services may not yet be quite ready to take on the operational capacity required to deal with Ealing's maternity users. Do you have any comments on that?
I have to say that I consider that one of the most sort of breathtaking statements within the email, because I mean, it seems to me that to say that the London Clinical Senate, which I have to say is a body which is not on the lips of every one of my constituents, you very seldom find people in the viaduct chatting about the London Clinical Senate. I'm sure it is important, but it's not something which we discuss at great length. To say that they've endorsed these doesn't mean a damn thing to the most of my constituents. The fact that the services aren't ready yet does. The fact that we're losing the maternity services does, and the fact that people will have to travel a long way does. And at the recent meeting of the CCG actually raised the question, what would happen to future capitation funding for a borough that has nobody born in it? And we already have this ridiculous situation where Northwick Park, which is actually in Brent, so people born in Brent count as residents of Brent, who are born in Northwick Park, even though anybody would say it's actually in Harrow, because the majority of the people who give birth there are from Harrow. But in terms of capitation and capital allocation, Brent gets that and Harrow doesn't. So if all the Ealing people are going to be born in West Middlesex, which is in Hounslow, there's another, I'm sure it could be dealt with, but these are things that haven't been thought through. And when I read the statement from Andrew Pike, and I have to say, I don't envy him his job as Assistant Director of Communications, but he is, for better or for worse. To actually admit that is, again, it's breathtaking, the fact that it's not even ready, for heaven's sake.
Can we move on now, please? I wanted to ask you about the issue of emergency care at Ealing Hospital. Could I ask you, in front of you you'll see another volume, it's headed volume 2, it's the second one.
Sorry, I have it.
I think that's volume 5. I think somewhere in the mass of papers there to your left, you'll see volume 2. Could you turn, please, to page 594. And what I'm taking to you while you're doing that, I'll explain. It's a letter and it's from Dr. Palmer, who is the chair of Ealing CCG. And I just wanted to ask you to comment on some of the matters contained in that letter, if you would.
Yeah, I have it here in front of me. And in terms of sort of the anodyne, it's wonderful because it really does sound as if Dr. Pangloss is the uncredited author of this. But I see the references in there to the community teledermatology service and the musculoskeletal services, but we're talking about maternity, we're talking about A&E. The problem with A&E at the present time is there is an existing A&E, an acute service facility at Ealing, but it's not A&E. Sorry.
Sorry, can I ask you just to pause there a moment? I want to take you to some specifics. I certainly don't want to circumscribe what you want to say to the Commission, though. So, do you want to finish that point?
No, that's fine. Yeah.
What I wanted to ask you about specifically in this document is what Dr. Palmer is talking about is the decision to support the change away from Ealing Hospital being a major hospital. And what he says at the bottom of that page is that it was such an important... such an important and sensitive change that a referendum of GPs was conducted. And as a result of that, it was found that there was overwhelming support. I want to read you the questions that were asked of the GPs and then just ask you to comment. Now, what the questions were asked were these. Do you agree or disagree that there are convincing reasons to change the way we deliver healthcare in North West London, including new standards for care in hospital and concentration of services to achieve them, and delivering some services that are currently delivered in hospital more locally? And those are the questions put to the GPs. Can I ask you to comment on whether or not you view that as providing a democratic mandate for what the GPs thought?
Well, I think Mr. Mansfield's arrived.
I hope he is.
So it's a very, very good impersonator.
I'm really sorry. Broken rail at Milton Keynes, and then...
Cow on the line at Basingstoke.
Wait, if you want the full story, I can't believe it.
Wrong sort of leaves on the line, wrong sort of snow, probably something like that.
Okay, look, I think these are pretty much weighted questions, but the other thing is to say that this has the entire approval of the GP community is all very well and good, but there are different issues here. It's one of the hardest things when you're talking about objectivity within the NHS is to separate the practitioner and the patient perspective. Now, I entirely understand and respect and I'm grateful for the practitioners. Obviously, there wouldn't be an NHS without doctors, consultants and surgeons, and nurses, but the patient view has to be heard as well. And it's all very well to say that the doctors know best and the patients don't have any say. And it's all very well to say that the doctors, and far be it from me to refer back to Myron Bevan's comment about choking their mouths with gold, but I mean, they've not done badly at the present time, and the position of the GPs within the CCG is so powerful that I would find it difficult to disaggregate their involvement within the CCG from their objectivity when it comes to talking about it. But you know, these questions, I'm sorry, any question which says delivering some services would be completely unacceptable by any legitimate polling organisation. You cannot say delivering some services. That is open-ended and, in effect, meaningless.
Now, I also wanted to ask you a little bit about the impact of the closures which had taken place already. And again, this is referred to in Dr. Palmer's letter at page 596. What is suggested there is that the closures took place in a planned and safe manner. Can you help with, to your knowledge, what the impact of the closures of the A&E at Hammersmith Hospital and Central Middlesex has been upon Ealing Hospital and the residents of Ealing?
Well, very much so. You'll hear in detail later on precisely how Ealing Hospital is actually failing to meet its targets and how waiting times are increasing and how the whole clinical aspect is currently failing. But look, when we spoke to Dr. Mark Spencer about this, he said that he was a GP in Acton, which he is, and he could get to St Mary's Hospital in a very short period of time. It later turned, he was talking about a fairly high-powered motorcycle. Now, I have absolutely no problem with motorcycles. I'm a great fan of them. But the idea that a pregnant woman can leap on the back of a motor guzzi and roar to St Mary's, or that a phlebotomist can jump on the back of a Lambretta LD175 and somehow get to the outer reaches of the borough is barking. I'm sorry, no, actually you can get to Barking by tube. But I mean, it simply doesn't make sense. So what I'd like to briefly, if I may, with your permission, I mean, there have been a whole number of cases where people have come to me with problems caused by the partial closure of the A&E. If I can just refer to one of my constituents, Mr. D, who has a very, very malign leg ulcer, which is being treated at the leg ulcer clinic at Northwick Park. And he needed a compression changing at least once a week for the next 8 to 12 weeks. I mean, his GP was unable to provide the service, who told him to attend a walk-in centre or go back to Northwick Park, or failing this, to attend an A&E. None of these actually worked. Previously he would have been referred to a district nurse, but because there's no district nurses, they will only visit immobile patients, and a practice nurse has to receive specialist training, and according to the staff at Northwick Park, treatment must be carried out by a healthcare professional. So when his GP told Mr. D to learn how to do it himself, or, and I quote, the marvellous old-fashioned expression, teach your wife how to do it. This was not only against the guidelines, but it's where the absence of the A&E has impacted dreadfully. My staff and I spent an entire morning on the phone to the GP surgery, to the walk-in centres, to Ealing CCG, Brent CCG, because, incredibly, there is now a rule that if you live within a mile of the boundary between two CCGs, you come under the one that you wouldn't think you came under. So his GP is in Brent, he lives in Ealing, but because he lives a mile from the Brent boundary, Ealing was responsible. We contacted district nurses, Northwick Park Hospital, the Wembley Walk-in Centre. We went on and on and on. Whereas before, either a district nurse would have come round and dealt with a compression bandage, or he could have gone to A&E. Now we have a man who's a shopkeeper, he's trying to run a business, and he is now having to somehow teach himself to change a compression bandage. I mean, I think he cavils at the idea that his wife, at the snap of a finger, is going to rush forward and change his compression bandage for him. And my office is spending half a day making phone calls there. Now, the idea that A&E, or the district nursing provision, was there to represent the people in precisely this claim is something that most people would think is so, but it simply isn't. And you cannot go to an A&E. Ealing A&E, I think, was originally anticipated that there would be 25,000 patients a year, and with over 100,000 patients a year, and rising. To even think of closing it is criminal, because in the context of rising demand, you could not have a steeper graph of demand.
Pause there a moment. I wanted to ask you about, you touched on it earlier, the configuration, the reconfiguration of the A&E department. Now what the Ealing CCG document says is that Ealing will continue to have a local A&E and 24/7 GP-led urgent care centre. What's your understanding of the provision for emergency services that is going to be at Ealing Hospital after the reconfiguration?
At the moment, we seem to have a ridiculous situation. Triage was originally invented, I think, at the Battle of Sedan, when they had 3 stages, or a triple stage, where there's a chance of you living, some chance of you living, or no chance of you living. And medical doctors then sort of basically threw people in a heap of corpses, having presumably removed their medals and valuables from them. The idea of triage, of having some sort of a gateway process, some filter mechanism, is an excellent idea. But under this new configuration, you've got a triage on a triage on a triage. And I'm ready to stand corrected. I'm told that only 4 blue light admissions are made per day on average to Ealing Hospital. And if that's the case, there's something seriously wrong. Why aren't ambulances bringing patients in there? And the answer is they can't, because they're being turned away. Therefore, it is immediately impacting on people. Also, we do have an issue because of the demographics. I make no apologies for it. We have a situation in this country, in this borough particularly, where a lot of people aren't registered with GPs. We have a huge transient population. We have a huge population that do not speak English as a first language, and we do not have an adequate GP service to cope with it. Polyclinics would have been ideal, would have been a wonderful answer, and would have been absolutely very, very helpful, but we don't have polyclinics like that. Therefore, the A&E still takes up the brunt of it, and the present A&E is overloaded, overworked, underfinanced, under-resourced, and under threat.
And what happens if it then becomes an urgent care centre and there is not, and no longer has capacity to accept blue light ambulances? What's the impact on your constituents then?
I'm really reluctant to be alarmist, because we're not here talking about some sort of theoretical construct of health provision in some sort of cool analysis. We're actually talking about blood, pain, hurt, life and death. And again, I'm not going to be alarmist, but this is something which you cannot take too seriously. If someone in an RTA cannot be taken to the nearest A&E, they'll probably die.
I wanted to ask you briefly about the other side of the coin from the acute services provision, and that, of course, is the out-of-hospital strategy and the primary care services. First of all, on the information that you have, how would you characterise the state of GP services in your constituency at the moment?
Very patchy. I mentioned earlier on the very, very large number of elderly single-handed practitioners in the west of the borough, and that certainly does have an impact. We have quite a few of them in mind. We have in Ealing North more removed towards health centres, where we have agglomerations of GP practices and services, which is a sign for the future. But we still have a great many GPs who will not accept more patients. Over and over again, people come to me and say, there's a surgery down the end of my road and I'm told they're not taking anybody else on. That is a huge problem, and I'm not going to criticise the GPs. I don't know how the structure works. All I do know is that people come to me and they say they cannot get a GP and they cannot go to A&E. That's when you have a problem.
And do you have any comment on the impact on GP services if they were to have an increased role under the new provision?
Well, you know, you can load the noble beast of burden up to a certain point and then the back breaks. I mean, I appreciate GPs get a decent wage nowadays. They probably wouldn't admit that, but it's not bad. But this is not actually about money. This is about time. And like most MPs, I do the old mystery shopper thing. I go to A&E at Ealing once a month, anonymously, and just hang around to get a feeling of that. I also talk to a lot of GPs. Not because of my own personal health circumstances, which are actually not bad at the moment, but I do talk to a number of GPs. I spend 10 minutes per client in my constituency advice surgery. Most GPs spend 7 or 8 minutes. They are being overloaded to such an extent that I don't know a single GP that actually has a lunch break. You know, they're all dining al desco. It's an extraordinary situation now where GPs are being massively, massively overloaded. And you can tell this because the lack of the community involvement used to get GPs in Rotaries to be active in local groups. They are so overloaded now that to say that you can shovel this onto the back of that body now seems absolutely ludicrous. I mean, GPs are not known for reticence when it comes for making these points vociferously, and I'm pretty sure that they will say this, but you can't simply expect primary care to take up the slack and remove all that need for acute services in that way. It just won't work.
I wanted to ask you to comment again on something that Dr. Palmer has said. I won't take you to it, but effectively, in Volume 2, in the same letter, she sets out the Ealing out of hospital strategy, and she refers to things which have been successfully implemented. And she references GP networks, integrated care for the elderly, pulmonary rehabilitation service, new diabetes pathways, increases in community dermatology and cardiology services, and so on. Are you able to comment on whether or not on the ground you've seen changes as a result of these initiatives?
I have to say there comes a point when you have expressions like diabetes pathways, and it sounds like something by the side of the Thames that you go for a walk on. I mean, it just sounds ridiculous. But look, what isn't mentioned there, and Dr. Palmer is a very, very good clinician and an extremely good doctor. I respect, I have a lot of time for her. But she's not mentioned the real secret of the success in most of those, which is community pharmacists. The biggest change we've seen in the last 5 years has been the rise of the role of the community pharmacist. You can get blood pressure there, you can get phlebotomy services, you can get travel advice, and you can even get some element of prescribing. Nurse prescribing, which came in, 15, 20 years ago, made a difference. But the community pharmacist is now the third leg of the stool. It's a really, really key person there. And I think Dr. Palmer's being a tad tendentious in claiming credit for that, because some of these pathways that she refers to are in fact more to do with that. The idea that GP surgeries have taken over those, in fact a lot of GP surgeries now have nurse practitioners within them, but in those cases that is part of the understandable evolution of primary care anyway, and it doesn't have to be either or. Most GPs I know want to have a 24-hour, 24/7 A&E because they need it. They are more than happy to do things like suturing in the surgeries which they never did before. I mean, you don't go to A&E for a few stitches now. But you can't have a complete handover from the one to the other. The GPs aren't ready for it, and there may well be advances in diabetes pathways, but there's an awful lot of other agencies working there.
I'm conscious of the time. I think we have 10 minutes of your time left. So
you make me sound dreadfully precious.
No,
I'm sorry about that.
not at all. Those are the questions I wanted to ask. I'd like you, if you could mind waiting there, the commissioners may have questions for you.
Yes, I've got one. I'm sorry. Can you hear? Does this carry all right?
Is that better? Yeah,
Brilliant.
it'll be recorded. Okay. Apologies again for being late, but there is a question left over from last week which I'm
going to carry forward to each of our sessions because I'm interested in the response to it. Mr. Jonathan Ramsey, he's Royal College of Surgeons. He was on the reconfiguration board, and he also established or helped to establish emergency standards, which apparently did not exist before the furore about weekend inability to service the public. But he has a point which I think I'd like to hear what you have to say about, and that he's saying, as far as acute treatment, in other words, A&E is concerned, it's much more efficient to have the specialists together in one place. And if you're going to have, in future, as a basic condition, an on-site surgeon or consultant, actually on-site, plus co-located with radiology, for example, that will mean this is the big debate. Can you have that in every A&E? He was saying it's not sensible, therefore you have to centralise. Now, I hope I've made the point clear, but that's the one I'm interested in.
You've made it extremely clear. It's a well-known truism that everybody in this country wants to have open-heart surgery in a cottage hospital. And you know, there is a slight contradiction there. 30 years ago, I worked for Dr. Howard Baderman, who's the man who invented the Bader wagon, which is a great A&E resus, cardiac arrest resus kit. But he loved gunshot wounds. And he was very keen on GSWs, and he wanted to have a central group within the United Kingdom just dealing with gunshot wounds, which, not surprisingly, was located in the Royal Victoria Hospital in Belfast. And he was very, very keen on that, but what it meant was that you couldn't have anybody who had any expertise with gunshot wounds anywhere else in the country. And so after a bit, you thought, well, it's ridiculous, you can't have that over-concentration. Now look, I can understand why specialist consultants want to gather around together. They want to have the most interesting patients. And the structure of the NHS in London is very much consultant-based. I mean, when I'm thinking of some of the Turnberg report, for example, identified, and that was, 15, 20 years ago, Turnberg identified an oversupply of hospitals within central London because that's where the consultants lived and that's where the patients came to. The patients would flow in from the outer reaches to bring in their fascinating, interesting cases to fascinated and interested consultants. Now, that was the structure of the NHS then, and I think that the answer is to have more consultants rather than to have the existing body of consultants concentrated in one particular area. Now look, centres of excellence always make sense. My wife did all her postgraduate work at the Royal Marsden, and you know, she worked in oncology. And that made sense. The Marsden was and is a centre of excellence, but it shouldn't be the only centre of excellence. What is wrong with having more consultants, a better funded NHS, and having the experts in the places where the patients live? And my wife used to say, why on earth does somebody come from Truro to South Kensington or to the Bud Flanagan for their oncology treatment, their cancer treatment? Why can't we do it there? And that seems to me the problem. I can understand the point being made, but I have to say that is life being looked at from the consultant's perspective or the clinician's perspective. I think the patient actually has a role here.
I was going to touch on various subjects. I want to, you may be interested in your comments. I have this running bee in my bonnet about perhaps medical politics. When you look at the map, I see these great institutions, and I trained at a great institution, all gathered together, as you say, and just beyond the area which we're dealing with, there is UCH, only half a mile down from St Mary's, and St Thomas's, and of course Chelsea and Westminster as well. There's a group of 4 or 5 very...
I would add the Marsden to that, out of filial loyalty.
My wife also wants to.
Oh, really? We speak later.
Yes. But, I mean, I suppose, touching on what you just said, why is it, and also in the knowledge that the trains go both ways, why if St George's went to Tooting and Charing Cross went from Charing Cross to Fulham, why can't St Mary's come to Ealing? And my worry is, I think you might want, that there is a kind of a, choose my words carefully, there is a kind of political clan or a area of perhaps the privileged who want still to have in Kensington and Chelsea and in... Now, am I being paranoid or?
Well, but my experience in the 10 years I worked at the Middlesex, we had a private patients wing, and I could never understand why we had a private patients wing, why we had the PPW at the Middlesex, why we had the Minto at St Mary's, until I read the history of the NHS and the history of Annar and Bevan, and understood how the NHS had come across and how that was part of the consideration that was given to consultants. And that's where the reality is that the consultants would prefer to live in central London, accessible to one of these hospitals, than they would to live in Southall. I can't imagine why. And there's, Northolt is a delightful place, and I wish they'd moved to Northolt. But there is an aspect to that. Now, the problem is, what do we do about it? How can we actually cope with it? And I think Turnberg was actually a very, very good stab at doing that. And as you rightly say, moves did take place. Do you know, the biggest number of complaints I get from constituents at the moment is about inability to actually get appointments, with hospitals where they've been referred to it. And I'm currently averaging 2 months for a response from the CCG. And I have to say, Sharon Hodgson's a marvellous woman, marvellously polite, but she says, look, I'm sorry, I'm trying, but you're getting responses in 2 months. The second volume of complaints is about accessibility. And the problem with Chelsea and Westminster, again, marvellous hospital when you can get there, very difficult to get to. And the chances of parking there are negligible. But I don't expect people to drive to hospitals. But it's very difficult. There's one bus stops outside. But to get from Northolt to Chelsea and Westminster means you have to change at least one bus, one tube, 2 buses. Very, very difficult. I would rather see the hospitals where the patients are. If you look at the fire brigade, fire stations in London are concentrated on property, not people. So you'll find most of them in the City of London or the commercial areas, because that was the imperative when the fire brigade was set up. Property mattered more than people. It seems to me when the NHS grew gradually, we can go right back to Barts maybe, but I preferred a little bit more modern, maybe from mid-Victorian times. It was to do with where the consultants wanted to be, not where the patients were. And just as much as we've moved tax offices, DVLA, the Royal Mint, various other people out of London, then what on earth is wrong with actually employing a few more consultants and having them where the patients are? Because not only do you have the advantage of the reassurance, because it's the sort of corrosive, sort of acid-like anxiety at the present time when people don't have a hospital near them, but also a good hospital does outreach, actually indulges in helping people, does health education. And that's the sort of thing we need. We need to know about that. A hospital shouldn't just be about treating patients when they're ill. It should be about preventative medicine. And you can't have preventative medicine if you've got to go to the other side of London to go to some sort of a clinic. So I must admit, I wish I was Secretary of State for Health. I would employ you and your wife immediately. And then we would reconfigure the whole damn thing in the interest of the patients, not in the interest of the bean counters.
Just to follow through on what you've been saying about transport links. The notion of centralising services is a bit peculiar when you're in Ealing, and it does mean you've got to travel that much further. But I wonder if you could talk about the various options. So, you talked about maternity, possibly people being expected to go across the M4 to West Middlesex. But what are the other options if in terms of A&E? Hillingdon, Northwick Park, what are the transport links like? And bearing in mind we are, for the catchment area of Ealing Hospital, we are looking at quite a deprived section of the population, presumably car ownership relatively uncommon and so on. Could you just talk a little bit more about that?
One of the things that frustrates me immensely about this is that Ealing Hospital is a brilliant transport hub at the present time. 5 buses stop at Ealing Hospital, including 2 24-hour buses. Ealing Broadway Tube Station, Central Line and the District Line, there are 6 buses go from Ealing Broadway straight to the hospital you can drop off at. It's a really, really good transport hub. It's so good that one of the reasons they have to charge for car parking there is people were parking there and going into town because it's such a good place to get to. The 92 bus, one of the best bus routes in London, runs all the way from St Raphael's up in Wembley to Ealing Hospital. So you can get there from virtually anywhere in my constituency. And Ealing Hospital's not been open that long. I remember very well the day it opened. But at that time, the transport was arranged to go to the hospital. Everything was moved around specifically to have done it. It took a damn long time to do that. To get from Ealing to Hillingdon is not easy. To get from Ealing, from my constituency, to Northwick Park is very, very difficult. One bus comes about every 17 minutes. It's very, very difficult to get to. And the idea of going across to St Mary's, although we can't all have access to Dr. Spencer's motorbike, but even if he would adopt a sort of a GP taxi service and sweep by and pick people up, I'm still not entirely convinced that we could get there in time. So the transport links don't work. People in central London don't understand that Ealing is a big borough, maybe the second or the third biggest borough in London. And we do need the transport links. Car ownership is low for two reasons. One is economic factors, and the other thing is that a lot of people live in bedsit, single flats, small properties where you can't have cars. I mean, that's just part of it. Thanks to the enlightened leadership of Councillor Bell and Ealing Council, we're actually giving planning permission for properties with no parking spaces. I'm sure he'll make the point himself. So it is very, very difficult. And it also leads to anxiety because we've not even mentioned patients' relatives. When someone is in hospital, their relatives need to visit, and that is part of the therapeutic process. Having a visitor is important. Now, I can well remember my wife saying that they used to lay out the ashtrays by the bed, for the visitors, and it was, those were different times. Nowadays, the visitors come, and it's actually part of the healing process. And a number of people who say to me, look, how on earth can I get to St Mary's or Hammersmith? Hammersmith is easier, but not the easiest. And there's also something profoundly wrong, I think, in our country when Charing Cross Hospital, just down the road from where I was born, could end up as luxury flats instead of providing health for the nation. What sort of a priority is that? I was going to say, I don't make a political point, but I'm a politician, I can't help it. I'm also a human being, and I'm also someone whose life's been saved by the NHS. I was born the same day as the NHS. My elder two brothers died, and they were born before the NHS. And myself and, I hate to say, my 7 brothers and sisters have all done rather well out of the NHS. It is important, and if I get a bit emotional from time to time, do you know, I'm not going to apologise.
Just one more thing. Going back to the process of the consultation, and you were talking about your constituents being confused by it and so on. We've had various references to the availability of the literature explaining what was in, leave aside how adequate the literature might be in actually explaining what they're planning to do, but the one question I'm keen to follow up is the question of availability in suitable languages and access to the detail of the report rather than simply a very abbreviated summary. Could you talk a little bit about that, whether it was actually, people could actually find it in a language they could understand before the decisions were taken?
Well, no, it wasn't. If you actually have a look at, the two main documents, obviously the Shaping the Healthier Future document, which has appeared in various guises. I think there's probably a 5-volume version of it somewhere, but you could apparently get hold of a copy. It wasn't easy. There's nowhere I could see a copy in any of the community languages. But the Healthier North West London document, which was sent out to people, has no facility whatsoever. And a lot of people I know would simply see that if they saw it at all in a community centre or GP surgery and take no notice. All it needed was to have one sentence written across the top in Urdu or Hindi or Somali or Polish or Tamil or any of the community languages. It just say this is important, or they could then raise it with the nurse or raise it with the receptionist at the clinic. It was a pretty poor job, and it almost, somebody said to me they're doing it on purpose. I'm not a conspiracy theorist, but if I was, that might well be a point.
I'm conscious of the time. I want to thank you very much for
Thank you, sir.
the presentation.